welcome to OsteoBites. It's our second session, and really excited to have you here. I am an osteosarcoma survivor, and I'm also the president and founder of MIB Agents. MIB Agents makes it better, MIB for kids who are in treatment for osteosarcoma. We have lots of programs that support that making it better goal of ours. There's lots of information on that on our website. I won't take our time here. OsteoBites came out of the Factor conference, where people would say to us, we need more throughout the year. We need more information. It'd be great to keep on top of what's happening in research and treatment throughout the year. And also our researcher physician friends have projects that they'd like to talk about. So we thought this would be a great way to get everybody together, ask questions, and get everybody on board to what's new and exciting. So with that, I'm very excited this week to have Dr. Matteo Trucco as our guest. Dr. Trucco is known to many of us who, of course, attend the Factor conference. He's the co-chair of Factor. He is at Cleveland Clinic. He works closely with Dr. Pete Anderson. He is also an MIB agent board member and the chair of our scientific advisory team. So with that, I'll let you finish the introduction, Dr. Trucco.
Hi, Matteo Trucco. Thank you, Anne. What Anne said, that's who I am. I mostly take care of patients with sarcomas, osteosarcoma, Ewing sarcoma, rhabdomyosarcoma. And here at the Cleveland Clinic, I run the pediatric clinical trials program. So developing new therapies for kids affected with sarcomas mostly, but any cancer. And thank you for the invitation to help answer some questions that the community might have. Again, not offering medical advice per se. That's what your doctors are for, but if there's kind of any overarching questions about osteosarcoma that maybe I can help answer for you, it would be an honor.
I'm Amanda, and I was diagnosed with OS in 1987 on my leg and my lung, and I have become involved with the OS community in about 2010, 2011, when I was diagnosed with breast cancer. And if you hear me speaking funny, it's because in 2018, I was diagnosed with ALS. So I'm still very active, and I will never stop advocating for the OS community. So thank you again for having me here.
Good afternoon. I'm Florencia Pistrito. I had osteosarcoma in 2014. So I have been 5 years in remission now, nearly 6. I am also the administrator of the Osteosarcoma and Ewing sarcoma support group. That is a global platform on Facebook.
With that, Dr. Trucco, over to you.
Okay. I'm just going to share a brief PowerPoint. A lot of the questions that we have circled around research and what research is being done right now. So can you guys see my slides?
Yep.
Yeah.
Okay. Yes. So very kind of broad strokes overview of research, and it kind of gets to why it's taking so long to come up with new and better treatments. The numbers, I mean, all childhood cancer in the United States, this is about 16,000. That's not just osteosarcoma, that's all of the cancer we see every year in the United States. It's about 16,000. And bone tumors only make up about 5% of that, and osteosarcoma makes up only a portion of those. And when you put it into context, adults see about 16,000 just sarcomas, and something like lung cancer, they're seeing over 200,000 patients a year with lung cancer. And so when you kind of think of why does an osteosarcoma get more attention, it's sort of a numbers game. It's just not as common as some other cancers, fortunately, because you don't want everyone to have osteosarcoma. But at the same time, it's frustrating and difficult for those taking care of these patients and for the patients themselves to kind of be in this small number that doesn't get the attention of pharmaceutical companies, of other entities as much as some other cancers. Osteosarcoma, usually it happens around the knee, but it happens in various other sites. And as we know, metastases happen in the lungs and other bones. And, you know, one of the organizations we have, especially here in the United States, that helps develop treatments for cancers like osteosarcoma is the Children's Oncology Group, where there's about 200 sites that team together to make sure every single patient with osteosarcoma is treated, and we learn from them so that we move things forward. If you've ever taken a class in statistics, you know that numbers matter, and you need a certain amount of power to make calculations to figure out whether or not treatment works or treatment doesn't work. And so you need to team up with all these sites so that those 600 or so patients with osteosarcoma that we see every year get counted and get included in the clinical trials and the analyses. So this is a Kaplan-Meier graph. Y-axis is the proportion and x-axis is the years. And so it's survival. So the proportion of patients that are still alive as time goes on. And what they're doing here, they're comparing 4 regimens. And so in an ideal world, you would have a line straight across the top because that treatment, everyone's still alive as the treatment goes on as years pass. As you can see, all of these have some drop off, and this is event-free survival. So what is an event? Events can be relapse, events can be death, whether related or unrelated to the cancer. You get run over by a bus, that counts as an event. Anything that kind of takes you off the clinical trial. And as you can see, if you kind of draw the line at 1 year up here, there's not a lot of difference between those lines. And if you go out to 2 years, okay, there starts to be a little bit more of a difference. We usually go out to at least 5 years because that's where we know that the curves tend to flatten out for cancer. And as you can see here, these kind of little tick marks around the big lines, that's the standard deviation. That's the kind of fudge factor that statistics have to regulate whether or not a difference between the lines really is true or significant. And it just so happens this is the graph for the mifemertide trial that was done years and years ago. This one was published in 2005. And first of all, they did a mess of kind of presenting it. But what I can tell you is the A here, the solid line, that's your standard of care map. Then the AMTP with the little dots, that's standard of care map with mifemertide. Then this line here with the dashes is MAP plus ifosfamide plus without mifemertide, which was worse. And then the DMTP, that is MAP plus ifosfamide plus mifemertide. And as you can see, for the first kind of 4 or 5 years, it looked like it was better. But then it dropped down, and actually it was worse, not significantly worse, but worse than the standard of care of MAP. And so this is the data that the FDA looked at and said, we are not approving this study. Now there was a follow-up when the data matured a little bit more, so now we're going out over 10 years out, and the curves kind of separated out a little bit better. Same design, same concept. If you look at event-free survival though, and here they made it a little bit nicer, the treatment with the best outcome is B plus, which is MAP plus ifosfamide plus mifemertide, and it's slightly better than the MAP alone, which is A. But it's not a huge improvement, and in fact they left out kind of the error bars here to see whether or not they overlap statistically. What the Europeans and what a lot of people kind of hang their hat on is overall survival. It does look like the treatment groups that use mifemertide have better outcomes compared to treatment regimens that did not have the mifemertide. Overall survival. So that doesn't even mean that these patients haven't relapsed. It just means that they're still physically alive. And I don't present this to you know, open the can of worms of mifemertide, should it be approved in the States or not, but just to kind of show you how it can take 10 years to get an answer, unfortunately. And if you try to, you know, see what the answer is too early, you don't have an answer. It's messy. And that's the challenge of clinical trials. That's why these things have to be done well and done in the time that it needs to really tease out the accurate response. And the only other thing I'm going to show is there were some questions about genetic testing, and we can go over it more when with the questions. But this is a paper that tested maybe I think about 40 patients with osteosarcoma and just listed all the mutations that they could find. And the one that you can see pretty consistently is seen as P53. That is the most mutated protein in osteosarcoma and the most mutated protein in cancer in general. And that's the target that Josh Schiffman, for example, is studying to see whether the P53 that elephants have works better, and you can put that into the cancer cells and maybe fix the problem. But beyond that, if you look, not a lot of these mutations are very prominent. Maybe you see something like, this is a mTOR mutation. Somewhere in the mTOR pathway, maybe 20% of patients have a mutation there. And all to say that when we look at the genetics of an osteosarcoma, they're all very different. And no two of them are alike. And so to be able to say, oh, we're going to study the genetics of these tumors and identify a target and develop a drug to hit that target, the numbers get smaller and smaller and smaller and smaller if you're only talking about 20% of those 600 patients, for example, might have that target that the drug can hit. So it complicates things even further. This paper wasn't published that long ago, I think sometime in the 2000s. And so it just takes a long time to get all this data. This is 40 patients to really power it so you can see a significant difference, or whether it's just kind of noise in the background, takes hundreds and hundreds of patients. And so it's another component to why things are taking so long to develop treatment. But rest assured, people are working on this, are working on it a lot, are looking at the genetics, are looking at new drugs, are looking at repurposing old drugs, all to try to move the needle forward. And
so really the takeaway on that chart is that osteosarcoma is many different gene mutations under one umbrella of osteosarcoma.
yes.
Right? Part one. And part two, talking about last week with the Osteosarcoma Project, we have the power to inform these charts and, more importantly, research moving forward. And we really have got to do that. We've got to come together as a community so that researchers have, I mean, what was the study size on that last chart? 40?
40.
like I mean, we can do better than that. We've really got to, there are many more osteosarcoma patients than 40, and there are many more osteosarcoma patients who will gladly help inform treatment. And we now have the power to do that with the Osteosarcoma Project. Certainly our tumors and our demographics and outcomes and all of that are tracked at the institutional level, but we need them tracked on a global level. And we're starting now with this partnership with the Osteosarcoma Project.
Yeah, and in fact, that was one center, a very prominent center that sees a lot of patients, but it took several years to get 40 patients. And, you know, a couple other places published very similar results. And in a sense, what if they had worked together? Could we have gotten it done faster? Could we have gotten more numbers that might have teased out a little more information?
You ready for questions?
Bring them.
Amanda, go ahead.
All right. So there are many patients that are confused about how necrosis impacts prognosis. Many are told that necrosis is not an indicator, but additional chemo agents are added if they have low necrosis rates. How would you explain the survival risk and recurrence risks with respect to necrosis percentages?
So there was a paper published many, many years ago, which is where we get the basis of tumor necrosis. And the way we built the treatment for osteosarcoma is, as most people know, kind of 10 weeks of chemo, local control, and then another 18 weeks of chemo. And that was more out of, I wouldn't say convenience, but logistical reasons, because it could take, you know, upwards of 10 weeks to get the prosthesis, get the metal implant for the surgery. Because again, these treatments are several years old, and we've just been doing it that way since then, because that's been the standard. And what's nice is after those 10 weeks, you can take the tumor out and see under the microscope whether or not the tumor is dead, meaning it's responding to therapy, or if it's not dead, not responding, and what percent is dying. And a paper was published that looked at, you know, a decent amount of these patients and looked at whether there was a cutoff where if it was more necrosis, meaning more of the tumor is dead, than a specific number, what the outcome would be, whether patients did better, versus if the necrosis was poorer, if those patients did worse. And the number that in that study seemed to create the biggest divide is 90%. So if more than 90% of the tumor is dead, those patients tended to do better. And if less than 90% of the tumor is dead, those patients tended to do worse. And I believe the numbers were something like, if you had more than 90% necrosis, the survival rate at 3 years was something like 86%, while if your necrosis was less than 90%, the survival rate was somewhere like 46, I believe is the number. So that is in a way a little bit reassuring. You know, you could say, oh, I have great necrosis, that's good, but it means 86% overall survival versus, so what if you're in that 14%? You have great necrosis, but you still don't do well. Similarly with poor necrosis, I mean, there's a big difference between 89% necrosis and 1% necrosis, first of all. And second of all, okay, you have about a 50-50 chance of survival. And which one are you going to be in? Are you going to throw away MAP therapy because you want to try something else? Nobody really knows what to do with that information clinically, is the issue. What we know is if your tumor is growing on MAP, that means it's not working. That means necrosis is doesn't matter what it is. Your tumor is growing. And so then that's when you have to change therapy. And that's usually when we do a surgery almost immediately. But, you know, we have this number of 90%, and all the doctors, all the oncologists get tested on it for their exams. But fundamentally, we're not treating 100 patients. We're treating that one patient, and what to do with that necrosis for that one patient is not clear. And so that's why there's a lot of confusion. We all have several patients who had fantastic necrosis and they did well. We all have patients who had terrible necrosis and they did well. We all have patients who had poor necrosis and did poorly, and we all have patients that had poor necrosis, did well. Every possibility, possible permutation exists, and that necrosis is kind of a blunt measure, fundamentally. And I think as we learn more about the genetics and the various aspects of the osteosarcomas, as Anne mentioned, they're not one disease. They're a lot of different subtypes of one disease. We'll get a more accurate measure of prognosis than necrosis.
I think there are other factors, though, besides necrosis that take into consideration for survival, like clear margins during surgery and stuff like that. So a lot of people in the Facebook group say, I only had 10% necrosis, do I continue treatment? But I think the clear margin is also important, right?
Oh, absolutely. I mean,
Okay.
If you've left tumor behind, that's not good.
Yeah.
You have a metastatic disease, that's not good, even if you have great necrosis. If, you know, we know that if you just do surgery, 20% of patients do fine just with surgery. We just don't know who those 20% of patients are. And that's based on before we had chemo, 20% of patients were cured with surgery alone.
Right.
So there's a lot of unknowns, unfortunately. And there's a lot of factors that play into it. And there are those patients with great necrosis and great margins and no metastases at diagnosis who we don't know why, but they recur. And we are also working on better ways of measuring who those patients are, or measuring tumor burden even after metastases, tumors are surgically removed. So we're working on it.
Yeah. Thank you.
Mm-hmm.
Florencia?
Yes, because you get to see the patients way much more often than the orthopedic surgeons. What would you advise to a person that has been given 3 different options for surgery, like limb sparing surgery, rotation plasty, or amputation? Do you believe that there is a difference in terms of getting rid of the cancer between these surgeries?
Yeah. So as in real estate, with osteosarcoma, it's all about location, location, location. So whether these options are available to you depend on the location of the tumor, the size, the blood vessels, if they're involved or not. My last 2 patients, both are probably heading towards amputation. And one of them, we even caught it relatively early. But it's in a bad location, and that's unfortunate. And so they don't have all those options. If a patient has all those options available, none of them are bad. It all depends what's right for that patient. For example, something like 90% of local control surgeries now for osteosarcoma are limb sparing. Okay. Most people would rather, from the outside, look like their limb is intact except for the scar, and that's fine. But from a, let's say, practical standpoint or activity, if somebody is into extreme sports, hiking, cycling, anything that's very active. In a sense, actually, amputation is probably more functional for those patients, because if you break an internal, like an artificial knee, or the metal rods that are put for a limb sparing surgery, that requires a surgery to replace them, and the bone and the metal don't act very good together, and so there's limited mobility and issues. Amputation, you have this external prosthesis, and you can run, jump, and if they break, you just get a new one, and they have specialized ones for various sports. The rotation plasty, where it's usually when the tumor is in the lower part of your thigh, you take that out, and then you take the lower leg, the calf, and the foot, flip it around and attach it, and use the ankle as a new knee. That's a surgery that is also extremely functional, because it takes what would have been an above the knee amputation and turns it into a below the knee amputation, which is just more functional. The more joints you maintain, the better. It looks weird if you Google it. It takes some getting used to, but again, extremely functional. And for the right patient, it can be the best option. I know patients who have gone with limb sparing surgery and been perfectly happy. I know patients who have gone with limb sparing surgery, hated it, and asked for amputation later. I know patients who have gone with amputation and been perfectly fine with it. I think studies have actually looked at quality of life, and those with amputations might have a little bit better quality of life, just again, because once you get over the amputation and the look of it and having to deal with the prosthesis, you figure it out and you go along your way. The internal prostheses, the limb sparing surgeries have constant mechanical issues and need revisions and so on and so forth. So there's no one answer. As far as kind of overall local control, all things being equal, they're about the same. I think for amputation, it's something like 99% local control rate versus limb sparing, it's 95%. But having a surgeon who knows what they're doing will tell you usually if limb sparing is even an option. And again, you need a surgeon who knows what they're doing, but what's best for which patient is completely individual.
Okay, here's an emailed question that came in. There's a standard first-line treatment for osteosarcoma, MAP, that seems to be universally followed, but the protocol for follow-up scans seems to vary by institution. My son receives PET scans and CT scans, where I've heard of other hospitals employing bone scans. Why isn't there a universally accepted protocol for post-treatment scans, and shouldn't there be one?
So there actually is one, but the standards, the guidelines have not necessarily kept up with technology, so to speak. So what a bone scan is you get an injection of a radioactive isotope that goes to the bones. Any place there's turnover of bone lights up. So the growth plates, for example, or if you break your bone, there's going to be light up there. PET scan is where you get a radioactive sugar that goes anywhere that something picks up sugar avidly, and tumors like sugar, and so they tend to light up. But so do other parts of the body. And again, if you have an infection or a wound or something, it's going to take up sugar too. So there are two technologies. Bone scan is older, PET scan is newer. And only recently have studies actually come out comparing the two and saying PET scan might be a little bit more sensitive and a little more precise. But if you look at all the textbooks and all the last big phase 3 protocol that a lot of people turn to get their recommendations for MAP therapy, it still mentions bone scan. And there's still some roles for bone scan, but I think the field is sort of shifting towards PET scan. But a study that was large enough comparing the two head to head has not been done to definitively say PET scan is the way to go. No kind of osteosarcoma governing body really exists, and even if there was one, they haven't officially said, hey guys, we all should shift to PET scan for follow-up on these scans. On top of that, you can order a PET scan, but the insurance has to approve it, and the insurance, a PET scan is more expensive, and so they're not necessarily going to approve a more expensive scan unless there's definitive evidence to support it. And even if there is, they need to review it themselves and say, yes, we agree. And so that's why there's a lot of variability.
It would be nice if there were a standard of care post-treatment on this level, especially if you're feeling like you really need, you think something's going on and you really think a bone scan, and maybe your doctor agrees, but you need kind of some documentation to go to insurance with to say, hey, this is standard. I should be getting a bone scan now, or I should be getting a PET scan now.
Yeah.
So what do COG guidelines, what do the Children's Oncology Group guidelines tell you?
Right. So the Children's Oncology Group guidelines are sort of, it's based on all the trials through Children's Oncology Group have what they recommend for, what they mandate for a patient on study, the follow-up that they want. Because as I showed, we're following these patients for 5 years to see if they relapse. And so they specifically say something on the order of imaging of the local site and the lung and the bone every 3 months for the first 2 years, then every 6 months for 2 years, then once a year onward. But that study was from now over 10 years ago, before PET scan was fully established. So it probably says it says bone scan. But if the technology that's better is PET scan, we're just not there yet. We haven't opened a clinical trial yet, and we haven't fundamentally tested bone scan versus PET scan. The other thing is, that's the criteria that were mandated on this study to answer the study question. And that's what we use as guidelines. We say it's good enough for the study, it's good enough for our patients. But, you know, in studies, they tend to ask a little bit more than what you might need necessarily. And everybody wants probably a little bit more imaging than less. But again, it's not like a standard of care that has been thoroughly thought out. It was, in the context of this study, this is the follow-up we want to answer the study question, but we tend to use it moving forward.
Is there a more accurate scan for the lungs beyond a CT scan?
No. CT right now is the most accurate thing we have.
Okay.
But then there's also different kinds of CTs, because the CTs now maybe make 1 millimeter slices. So each slice of your CT is 1 millimeter versus, 3 millimeter, 5 millimeter. 10 years ago, they probably weren't quite as accurate. And you say, oh, well, I want the best one. I want the 1 millimeter scan. Well, that's also a lot more radiation. So again, it's a balance. And most studies don't kind of specify, hey, we need it down to the 1.5 millimeter necessarily.
With regard to genetic tests, is it common for one biopsy to have a different gene mutation from another biopsy of the same patient? So biopsies from different different dates, new mutations, maybe old ones disappeared, etc.
It's even worse than that. You can biopsy the same tumor separately and submit them if you submit them separately, and they will probably come up with different genetic mutations, especially in a tumor like osteosarcoma, because not all the cells in that osteosarcoma are the same. There are pockets of low oxygen levels, and that influences the genes. There are pockets of necrosis. There are pockets of bleeding. There's some cells that are closer to the blood vessels, some more far away. chemotherapy affects the genetics of these tumors. And so a biopsy you get when a patient is newly diagnosed versus a biopsy you get at the third relapse is bound to be different.
Our time is up. I have to tell you, we probably got 30 additional questions via email in the meantime. We're going to choose some of those questions and put them on our social media pages to be answered. And so we'll get as many, we'll get Dr. Trucco to answer as many of those as possible.
Rapid fire, yeah.
Also wanted to note that Dr. Trucco, actually along the lines of these types of questions with regard to surgery and what the tumor is like post 3 months of chemo, et cetera, there's a sort of a groundwork being laid for a clinical trial that we on OsteoBites will have the opportunity to help inform whether that clinical trial gets moved forward. So that OsteoBites is going to be on the 30th, so not next week, but the week after. And next week is the Osteosarcoma Institute. Again, if you weren't with us last week, Osteosarcoma Institute, they're the people who have funded for the osteosarcoma community the osteosarcoma hotline, so you can pick up the phone and talk to a nurse navigator who is a registered nurse who is in contact with some of the top pediatric oncology doctors in the country, and we'll get your question answered. You'll hear more about that next week with Dr. Lee Hellman, who's from Children's Hospital Los Angeles and is on the Osteosarcoma Institute board of directors. And it's a phenomenal group that does so much for osteosarcoma. So I hope you tune in next week, same time, same place. We'll have information, of course, on our social media. And I think we're starting to get these things out on Mondays as well. So if you haven't signed up for MIB Agent Intel, which is our email blast, please do go to our website and we'll get that information out to you. In the meantime, thank you very much, Dr. Trucco, for sitting in the hot seat and getting all of these questions answered for us, and more questions to come. Thank you, Amanda and Florencia, for what you do for us every day in the osteosarcoma community. Always there for us, always answering when we need someone to listen, someone to care, someone to tell us where to go for resources, what you do, how you do it through your groups is so appreciated and so valuable. Thank you. So that's it, guys. We actually have a survey today. If you wouldn't mind filling that out after, it should take you like 3 minutes maybe. If you can fill that out, that'd be awesome. And we'd love to have your feedback, and we'd love to see you next week with the Osteosarcoma Institute. So thanks, everybody.
Thank you.
Thank you. I really enjoyed it. It was really good.
Great. Thank you, Florencia. Thanks, Amanda. Thank you, Dr. Trucco.
Thank you.